It's easy to forget about our veins, isn't it? Just quietly doing their job, carrying blood back. But when a blood clot messes that up, things can get pretty serious pretty fast.
Yeah, exactly.
So today we're diving deep into venous thromboembolism, or VTE. This is, well, absolutely vital stuff for your MSRA revision. We really want to give you a solid handle on it.
Spot on. Think of this as your, high-yield VTE guide, straight from the revision notes you've been looking at.
Right.
We're aiming to cover all the key bits, what it is, the causes, how you spot it, treatment, what might happen down the line, the whole picture. Let's make it stick.
Okay, brilliant. So let's start right at the beginning. What exactly is VTE?
Well, basically, VTE means a blood clot forming inside a vein. Simple as that, really.
Okay.
The two main types you hear about are deep vein thrombosis, DVT, which typically happens in the deep veins of the legs or pelvis. And then there's pulmonary embolism, or PE. That's when a clot, often from a DVT, breaks off, travels through the bloodstream, and gets stuck in the lungs.
Right, so it travels.
Yeah, and the key thing to grasp, honestly, is that these aren't just minor inconveniences. They can be really serious, even life-threatening, if you don't catch them and manage them quickly.
Okay, that's clear. So how does this clotting actually start in a vein? What kicks it off?
The classic explanation for this is something called Virchow's Triad. It's like a three-part recipe for clot formation.
Virchow'striad, okay.
Yeah. You've got, number one, sluggish blood flow, which we call stasis. Number two, some kind of damage to the lining of the blood vessel, the endothelium. And number three, the blood itself being more likely to clot than usual. That's hypercoagulability.
Right.
Often it's not just one of these, but sort of a combination that sets the stage.
Can you give us some real-world examples for each part of that triad?
Sure, yeah. So blood stasis, think about blood just not moving efficiently, like someone stuck in bed after a big operation, or even just sitting still on a really long flight. Your leg muscles aren't pumping the blood back as well. Or someone with heart failure, if the heart's not pumping strongly, blood can pool in the veins.
Makes sense.
Then endothelial injury, that's damage to the vein wall. Surgery is a big one, obviously. Or physical trauma, like a bad knock. Even putting in a central line, a catheter into a big vein.
Yeah.
Interestingly, lines in the femoral vein down to the groin seem riskier for this than ones in the subclavian vein near the collarbone.
Oh, okay.
And finally, hypercoagulability. This is where the blood chemistry itself is altered, making it clot more easily. Cancer can do this. Pregnancy, too.
Right.
Hormones are involved, so the combined contraceptive pill or hormone replacement therapy. And then there are inherited conditions, genetic factors like factor V Leiden or specific prothrombin gene mutations. Certain medical conditions, too, like antiphospholipid syndrome, really push the balance towards clotting.
Wow, okay.
And, often it's the mix, isn't it? Someone might have a mild genetic risk, then they have surgery, they're immobile afterwards. Right. Boom, the risk shoots right up.
Yeah, it's like a perfect storm sometimes. So, digging into those risk factors a bit more, what are the really key ones we need to have on our radar for VTE?
Yeah, good question. We often split them into acquired risks, things that happen during life, and inherited ones.
Okay.
So, acquired risks. Well, recent major surgery or being hospitalized for anything significant, especially if you're not moving much. Just prolonged immobility generally is a major factor. Having active cancer is a really well-known one. Pregnancy and the period just after giving birth.
Right.
Those estrogen-containing meds, we mentioned the combined pill, HRT.
Yeah.
Some other medical conditions can increase risk too, like heart failure or inflammatory bowel disease. And just getting older, unfortunately, increases the risk. Oh, and having a general anesthetic.
Okay. Quite a list. And the inherited ones, the genetic side.
Yeah, the main inherited ones, or thrombophilias as they're called, are things like factor V Leiden. This is where your blood doesn't respond properly to one of the body's natural clot busters. And the prothrombin gene mutation, which means you make a bit too much of a key clotting protein. Also, deficiencies in other natural anticoagulants like antithrombin or protein C and S. These basically all fit under that hypercoagulability arm of Virchow's Triad.
Right. So some people just have this background tendency. What are the sort of common everyday things that should really make us think VTE risk when we see a patient?
The big hitters you see again and again are active cancer, being pregnant or recently postpartum, older age, obesity, having had a VTE before, or a strong family history of clots. Then there's immobility, being in hospital, having had an anesthetic, and specifically having a central line in the femoral vein. That one comes up a lot.
Okay.
And don't forget those underlying conditions that really ramp up the risk. The thrombophilia, as we mentioned, heart failure, antiphospholipid syndrome, Beclos disease, even some less common things like polycythemia, nephrotic syndrome, sickle cell, PNH, hyperviscosity, homocystinuria. It's quite a spectrum.
And you mentioned medications too, besides the pill and HRT.
Yeah, absolutely. So with the combined pill, the third-generation ones seem to carry a slightly higher risk than the second-gen ones, probably down to the type of progestogen used.
Interesting.
And HRT, the risk seems a bit higher if it's combined estrogen and progestogen versus estrogen alone. Others to be aware of include raloxifene, tamoxifen, often used in breast cancer context, and even some antipsychotics like olanzapine has been linked.
Right.
But here's a really key point, maybe a bit surprising even with all these known risks. Something like 40% of people who get a PE, well, they don't have any obvious major risk factors identified at the time.
Wow, 40%, that's huge.
It is. It just shows it's not always straightforward.
Definitely something to keep in mind. Okay, so we know the risk factors, the triad, but what's actually happening biologically when a clot forms? What's the pathophysiology?
So it's basically the body's normal clotting system going into overdrive
Right.
inappropriately inside a vein. You get this cascade effect where various clotting factors in the blood get activated, one triggering the next, and the end result is producing fibrin. Fibrin is like this sticky mesh that traps blood cells and forms the actual clot.
Right, the mesh.
Exactly. And Virchow's triad explains why this might happen abnormally. Slow blood flow lets those activated factors hang around and build up. Damage to the vein lining exposes stuff underneath that triggers clotting. And if the blood's hypercoagulable anyway, it doesn't take much to set it off.
Mm-hmm.
So when this clot forms in a deep vein, say in the leg, that's your DVT. The big worry then is a piece breaking off an embolus.
Yeah.
That embolus travels up through the bigger veins, through the heart, and it gets pumped into the pulmonary arteries in the lungs. If you get stuck there, that's a PE.
And that blocks the blood flow in the lungs.
Precisely. It obstructs blood flow, which means less oxygen gets into the blood. It can damage the lung tissue itself. And if the clot is large or there are multiple clots, it puts a massive strain on the right side of the heart trying to pump against that blockage. That's when it can become really life-threatening.
Gosh, okay, this sounds, well, potentially quite difficult to diagnose sometimes, especially if symptoms overlap with other things. What else might look like VTE? The differentials.
Yeah, absolutely crucial for revision. You have to think about what else it could be
Mm-hmm.
because the treatments are totally different.
Right.
So for leg symptoms, the pain and swelling of a DVT, you could be looking at a simple muscle strain or injury, or cellulitis as a skin infection, or maybe even a blockage in the lymphatic system causing swelling, like lymphedema.
Okay.
And for PE symptoms, the chest pain, the breathlessness, well, that could be pneumonia, could be a heart attack, angina, even a panic attack can feel similar sometimes.
So how do you tell them apart?
That's where the investigations come in. We use imaging, usually an ultrasound for a suspected DVT, or a CT scan with contrast, a CTPA, for suspected PE. Blood tests like the D-dimer can be helpful, especially for ruling it out if it's negative in a low-risk patient.
Mm-hmm.
And, of course, a good clinical assessment using things like the Wells score to figure out how likely VTE is in the first place. All these tools help us narrow it down and hopefully rule out those other conditions.
Got it. And in terms of just how common this is VTE something we see a lot?
Yeah, unfortunately it is. It's a pretty significant issue for healthcare systems. In the UK, the estimate is roughly 1 in every 1,000 people get a VTE each year.
1 in 1,000.
Yeah. And while it can happen at any age, the risk definitely goes up as you get older. And like we said, certain groups are at much higher risk post-surgery patients, people in hospital for other reasons, those with active cancer. So yeah, clinicians definitely encounter it frequently.
Okay. So we know who's at risk, what it is. How does it actually look when a patient presents? What are the clinical features we should be watching for?
Well, it really varies. It depends on whether it's a DVT or a PE, and frankly, how big the clot is.
Right.
For DVT in the leg, the sort of classic picture is pain in just one leg, often like an ache or a cramp. The leg might be swollen compared to the other side. It might feel warm to touch, and the skin might look a bit red or discolored.
Okay.
And this is really important, maybe up to half of DVTs don't actually cause any noticeable symptoms at all. They can be silent.
Half. Wow.
Yeah. And then for PE, pulmonary embolism, the symptoms often hit quite suddenly. The big ones are shortness of breath, dyspnea, and chest pain. Often it's a sharp pain, worse when you breathe in, which we call pleuritic. People might be breathing fast. Tachypnea, have a rapid heart rate. Sometimes they might even cough up a bit of blood. Hemoptysis. In really bad cases, they can be in clear respiratory distress, low oxygen levels, or even collapse.
Sounds dramatic.
It can be, But again, like DVT, PE has this huge range. It can be incredibly mild, easily missed, or a massive life-threatening emergency. And sometimes it too can be silent, found incidentally on a scan done for other reasons.
Okay, so with that huge range of symptoms, or sometimes no symptoms, how do we actually investigate properly when VTE is on the cards?
It's usually a mix of things: imaging, blood tests, and that clinical assessment piece.
Right.
If we're thinking DVT, the go-to imaging is usually an ultrasound of the leg veins. It's pretty good at showing if there's a clot there. If PE is the concern, then the best test is usually a CT pulmonary angiogram, a CTPA. That involves injecting contrast dye and taking detailed pictures of the lung arteries. It can show clots really clearly where they are, how big they are.
Okay.
Blood test, the main one, is the D-dimer. It measures fragments produced when clots break down. If it's negative in someone we think is low risk, it's quite useful for ruling GTE out.
But if it's positive?
If it's positive, it doesn't automatically mean VTE. Lots of other things like infection, inflammation, recent surgery, even pregnancy can raise D-dimer.
Okay.
So a positive result usually means we do need to go on and get that imaging, the ultrasound or CTPA.
Got it.
And then clinical assessment is key throughout. We use scoring systems like the Wells score for both DVT and PE. These help us estimate the pretest probability, how likely is VTE, before we do the tests, based on their symptoms, signs, and risk factors. That helps guide whether we start with D-dimer or go straight to imaging.
Okay, that makes sense. So let's say we've done the tests, confirmed a VTE diagnosis. What's the management plan look like?
The absolute cornerstone, the main treatment, is anticoagulation, blood thinners.
Right.
The main goals here are: 1, stop the current clot getting any bigger; 2, prevent new clots from forming; and 3, reduce the risk of long-term problems. Now, which anticoagulant to use, how it's given, injections or tablets, and for how long, that all depends. It's very much tailored to the individual.
What does it depend on?
Things like, was it a DVT or a PE? How big was it? What triggered it, if anything? Does the patient have other medical problems? What's their risk of bleeding on anticoagulants?
Yeah.
It's a balance.
Okay, so it's individualized.
Definitely. Beyond the drugs, other things can help. For DVT, compression stockings were often recommended to help with swelling and maybe reduce the risk of post-thrombotic syndrome later on.
Right.
Getting people moving again, early mobilization, is generally encouraged once it's safe. And in very specific cases, like if someone absolutely can't have anticoagulants or they keep getting PEs despite treatment, they might consider putting in an IVC filter. That's like a tiny metal cage in the main vein coming up from the legs, designed to catch large clots before they reach the lungs. But that's not routine.
Understood. So once someone's treated, what's the outlook? What's the prognosis generally like after a VTE?
It varies quite a bit. Depends on factors like how big the clot was, where it was, how quickly they got diagnosed and treated. Also depends on their underlying risk factors, if they have ongoing cancer or something, and just their general health otherwise.
Right.
But generally speaking, with good, timely treatment, most people do recover well. And the risk of it happening again can be lowered significantly with the right anticoagulation strategy.
It's good to hear.
It is. But we do need to be realistic. VTE is associated with significant morbidity, ongoing symptoms, reduced quality of life, and unfortunately mortality too, especially with big PEs or if clots keep coming back. And there are potential long-term complications to think about.
Okay, so that brings us neatly onto complications. What are the main long-term problems we need to be aware of after VTE?
Yeah, there are a few key ones. Probably the biggest concern is recurrent VTE getting another clot later on. It's pretty common, actually, which is why anticoagulation duration is so important. Another serious one, mainly after PE, is chronic thromboembolic pulmonary hypertension CTEPH. That's where clots in the lungs don't dissolve properly and cause persistent high blood pressure in the lung arteries, which can strain the heart over time.
Okay, CTEP.
Then, after a DVT, you can get post-thrombotic syndrome, or PTS. This is basically chronic symptoms in the affected leg: ongoing pain, swelling, skin discoloration, heaviness, and in bad cases, even skin ulcers that are hard to heal.
That sounds quite debilitating.
It really can be, yeah. It significantly impacts quality of life for some people. And finally, the complication of the treatment itself is bleeding. Anticoagulants work by making blood less likely to clot, which is great for VTE, but it does increase the risk of bleeding elsewhere.
So it's always a balance.
Exactly. Weighing the risk of clotting against the risk of bleeding. But the good news is that getting the initial diagnosis right and starting appropriate treatment promptly really does help minimize the chances of developing these longer-term complications like CTEPH and PTS.
This has been incredibly clear, really helpful. To help lock this in for the MSRA, have you got any sort of memory aids or maybe an example question?
Yeah, absolutely. For Virchow's triad, that fundamental concept, a really simple mnemonic, is EASE. S for stasis, H for hypercoagulability, and E for endothelial injury. She-E. Helps keep those three pillars in mind.
Stasis, hypercoagulability, endothelial injury. Nice. I like that.
And thinking about an MSRA-style question, you might get something like, a 65-year-old man is 2 days post-op after a hip replacement. He suddenly becomes short of breath with sharp chest pain. His oxygen sats are 90% on air. Heart rate is 110. What's the most likely diagnosis?
Right, classic scenario.
Exactly. Given the recent major surgery, immobility, and sudden onset cardiorespiratory symptoms, the answer they'd be looking for is pulmonary embolism. For just telling DVT and PE symptoms apart in your head, think location. Leg symptoms, think DVT first. Sudden chest symptoms, think PE first. It's obviously more complex, but as a starting point.
Yeah, a basic anchor.
Yeah. And one last tip. Try actively linking the risk factors back to HHE. So, bed rest, that's stasis.
Right.
Surgery, endothelial injury primarily. Pregnancy, that's hypercoagulability. Making those connections helps cement why those factors are important.
Fantastic tips, really practical. Okay, so if we had to boil it all down, what's the absolute key message about VTE for MSRA revision?
I think the main thing is VTE, both DVT and PE, is common, it's serious, but it's generally manageable if you recognize it and treat it properly and promptly. So having that solid grasp of the causes, the risks, how it presents, how you investigate, the treatment principles, and the potential complications, that whole package is really what you need for the exam.
Brilliant. And for everyone listening who's deep in MSRA prep and wants more resources, definitely check out passthemsra.com. And there's also freemsra.com for some great free materials too.
Yeah, definitely worth a look. And maybe just a final thought to leave you with. Start thinking about those subtle differences in how patients present. How might slightly different symptoms or signs point you more towards a DVT versus a PE? Getting that clinical feel, that nuance, is really key as you develop